is that I had a number of people in my family who were artists and dancers. And I always thought to myself that if you got to do what you love to do best in life as your profession, that would be wonderful. And I thought to myself, what do I like to do? And it was long conversation, meaningful conversation. So I think that led me in the direction of wanting to be a therapist. I think the biggest professional obstacle is probably not so much an obstacle for women today or for anybody today, but when I entered the field, there was a huge differential between people with psychologist degrees and people with medical degrees. And my postdoc was in an institution that didn't know what psychologists were. I was the first postdoc, the first psychologist who was doing something other than testing. And I think my biggest obstacle is that I didn't have an MD and that I wanted to be taken seriously at the doctoral level, but I didn't have an MD. I think those sort of status differentials are better today than they were back then. But I think not having gone to medical school was probably my biggest obstacle. When I have a patient who needs a medication, I know exactly what they need, and I can't find a reasonably priced available psychiatrist, yeah, then I wish I went to medical school. But I don't think that I would have learned at medical school or through the residency and rotations what I learned in graduate school and practicing as a psychologist. So in the long run, no, but I still have fantasies at this ripe old age of going back to medical school. I don't think I'm actually going to do it. Things have certainly changed. When I started, there were probably 75 to 80% male to female in the field, in the mental health field. Social workers really weren't doing therapy, and their psychologists were sort of just entering the field as independent therapists. So it was more men than women considerably. And now if you look at graduate schools, classes are half and half or 60-40 women. It's not at all unusual for Dr. So-and-so to be a female instead of assumed to be a male. And there's actually a dearth of male therapists around who are trained in the anxiety disorders field as clinicians. Now, in the academic world, I think it's still more male dominated, but just barely. And in the clinical realm, just looking for somebody to do competent therapy, I think it's dominated by women at this point. Good question. It's, I would say, no more different than in the general sort of natural arising of women's rights and responsibilities and prominence in the general public world. I don't think it's that different. I think it was, for me personally, I don't feel like it was a major impediment for me at the beginning. It was more about the status differential between physicians and psychologists than it was between men and women. Because I went straight into clinical work. I did not aspire to be in the academic world where it really did make a difference. I aspired to go out there and start practice right away, which is why I allowed myself to go get a degree that didn't exist either. I was in the first PsyD program that ever was created and is no longer in existence. And I was the second class of people. So there were 5 people ahead of me who got PsyD degrees and then me. So at that time, PsyD was not recognized as a thing, and certainly didn't have the equal status to PhD. So it really did depend on your own, what you were able to do and demonstrate to your colleagues of what you knew and what you were able to do. And of course, we had much more clinical training than the PhD students. So we entered the field well prepared. And this is something I don't regret. And I think of the class of PsyD students that I was in, we were half and half. There were 8 of us, four men and 4 women. So, good question. I think that I had been exposed to sort of publish or perish academic life in other arenas, and I knew that I did not want to participate in that culture. That I didn't want to be a sort of competitive. The sort of the way I looked at the academic community was that it was very, very competitive, and I didn't feel like that was going to lead me to have long, meaningful conversations. I wanted to go straight into the clinician world, and I was pretty sure that I would be good at it. And I didn't want to. I didn't have a need for a PhD. I wanted to get as much clinical training as I could get, and I was attracted to the creativity of the people who formed the program, the PsyD program, because they were really very cognizant of all the things that were lacking in a PhD program to actually create a real clinician. So it was a great program, and I have no regrets about that at all. Great question, and it shows me how young you are. There was no such thing as anxiety disorders in 1970. Back in the day, that would have been DSM, the sort of just the DSM-2 starting to come in. Was DSM-1 really. There was no specialization of any sort in psychology. You joined a school like Adlerians or Jungians or client-centered or something like that. And you treated everybody with the same treatment that you learned how to do by joining that school. And people were not, there were no specializations. The specialization in anxiety disorders, or actually it started out as agoraphobia with panic, was a brand new idea. And the idea that there was no mood disorder clinics or postpartum women's anxiety, whatever. There was nothing. Everything was clumped together, and you did therapy. And that included psychotic patients and everybody else. You used your school that you had learned. And you treated everybody with the same methodology. And then if they got really bad, you put them in the hospital and hoped somebody else would help them, which is why I then went to a postdoc in a psychiatric hospital, because I wanted to learn how to treat those people. So, but it was a very, very different world. When we started the agoraphobia clinic, is what we called it, in 1978, it was still DSM-2. There was no such thing as panic disorder in the DSM. And we were greeted with great skepticism and hostility, because the idea of that was that it was superficial treatment. It wasn't getting to the deeper issues underneath. And so therefore it would also be simultaneously superficial and dangerous. And the idea of clumping people together in groups or individually that all had the same sort of diagnostic picture was not something that was done. There was the beginnings of doing that for some research, mostly biologically oriented research, but that was it. It was a very different world. A great story. There was this amazing woman named Zelda Milstein, who was lay. She was a housewife in Piceville here in Baltimore. And she stumbled into the work. She was agoraphobic. She's housebound for many years. She stumbled into the work of Claire Weekes, who was an Australian family doctor who was brilliant and wrote these very down home, repetitive, lovely series of books, and had a radio show, and was advocating self-help for agoraphobia, and for, quote, nervous disorders, who actually, in her own way, preceded ACT by decades and changed the world of anxiety treatment from basically all self-regulatory kind of skill development teaching, or digging around in your unconscious for the things that the anxiety might mean, into a much more acceptance-based or third wave kind of thing, but way before Stephen Hayes was doing his work or anybody else. Zelda had used the books of Claire Weekes to get herself out of the house and to get well herself. And she got on a mission to find and treat and help other people with the same problem. And she approached people at the hospital. She was a volunteer in the drug clinic, actually, and the methadone program. And she approached the hospital authorities saying that she wanted to do this. And so she finally got in the hands of somebody who was very open-minded, and they decided to look around for a heretic to work with her. And that was me. So Zelda and I and Doug Hadland, who was my service chief, went up to Philadelphia to see what Diane Chambliss and Alan Goldstein were doing. They had one of the very first programs in which they were trying to figure out how to help people with agoraphobia, which they had defined brilliantly as a complication of panic disorder. In other words, the fear of panic rather than the fear of leaving the house. And that original reanalysis article was very influential in the field. That was in the early 70s, they wrote that. And so they put together their ideas with those of Manny Zane, who had developed something called TERAP, Territorial Apprehension is what it stood for, in which he had people who used to be agoraphobic taking people out of their houses to go face their fears and not be agoraphobic anymore. But it was very, very elementary. And there was Manny Zane in New York at the White Plains Clinic, who was also doing something similar. So we went up to Philadelphia and we listened to them talk. And then we went in the Philadelphia subway system with a bunch of patients trying to figure out what you should do, and came back. And the day after Christmas, 1978, Zelda and I were sitting in a room with 8 agoraphobic women trying to figure out what we were going to do with their 8 phobic companion husbands sitting out in the hallway with Zelda's husband, waiting for us to somehow be helpful. And that was the beginning of it. Well, I've certainly hired a lot of them, and I've trained a lot of them, and mentored a lot of them. I don't know that I've done anything specifically feminist, except I did a series of workshops in the 80s for some kind of organization called Women Working or something like that. So I've occasionally done workshops and things like that. But I think once I actually got involved in the field of anxiety disorders, there were women leaders, not just me. I wasn't alone at all. In fact, Geraldine Ross, who was the original founder of the Phobia Society, which became ADAA, was instrumental in developing the field by bringing people together. And many of the people she brought together were women. All of the executive directors of the Phobia Society and the ADAA from the beginning have been women. So there have been people, I would say some of those executive directors, particularly Elise Mussin, taught me a lot about sort of organizational management and the things that you have to do to keep a big organization together. Certainly Geraldine was a great leader. And I think, you know, there were committee chair who were leaders, and then who, you know, and people on the board. There were women on the board from the beginning. And part of that, I think, is that when Phobia Society was formed, it was formed from the bottom up. The people who were on the original board were, some of them were people who had anxiety disorders and who, because there was no effective treatment available anywhere, were consumer advocates and were pushing to make an organization that would develop treatment and disseminate information. And so there was always a contingent of active, interested, intelligent women, many of them without professional credentials, but who had definitely a lot of skin in the game because they were trying to push the field forward, and so they gathered together people in the biological sciences, psychiatrists, and anybody they could who showed an interest in the field. And so those women who, you know, someone like the names are escaping me right now, but people that I knew way back, who were just people suffering from anxiety disorders who were just insisting that the world start paying attention to them. They were not the worried well who, you know, that for whom it was just a privilege to talk about yourself. They had serious conditions and they wanted some help. So they spearheaded things. It's a tremendous amount to me. Geraldine was a friend, not just someone who ran or started ADAA. And so I still miss her. She was an important influence on my life. So to have had the people at ADAA, the board, decide that I was going to receive the first of the awards was very meaningful to me. I mean, I had been extremely active in the organization, and I guess it just sort of seemed like it, you know, it should come to me because I was just so active. I had been the chair of the consumer and clinical tracks of the conference for years. And this is before computers. That means like big piles of paper and poster board and stuff all over your living room floor trying to put together a conference. And Geraldine had been sort of the spearhead of the entire mission. And so it just felt wonderful to be honored at that time. Well, I think about that also in terms of the Anxiety and Stress Disorders Institute, which I run. And I think a lot of what's really important in women's leadership is paying attention to relationships. You can't pretend that money isn't involved or that things like status is not involved, but you have to nurture relationships in order to be able to lead. And you also have to, I don't know if the term lead from behind or how you do it. You can't be, your ego can't be the most important piece of this, and it can't show. You have to have a willingness to have other people take credit for things. You have to promote other people's well-being and prominence and originality and creativity. And I think that that women, I mean, not that men can't do it, but that women may have a leg up on those kinds of qualities. I prefer organizations that are not hierarchical And I think that ADA has a pretty non-hierarchical structure. Pretty much anyone who has a good idea can find a place to express that idea. And if you really want something to happen, you can make it happen with the help of people who are who nurture their members or their colleagues. So I think that's all part of it. That's a hard question. I was thinking about that before. I think the worst piece of advice that I got was to join a school and stick to it and know how to do one thing well. And again, that was in graduate school. You know, I was attracted to everything. I was very much an integrationist. I wanted to take whatever I knew and add into it everything else I could learn. And that is not the way of an advocate of a particular school or method or model. And I think the idea that you have to pick something and stick to it is really bad advice. So that would be the bad advice I got. I didn't follow it. In terms of good advice, probably the best advice that I got in my first year as a postdoc, I used to come home from work. I was at Shepherd Pratt Hospital working in the inpatient unit. I was completely in over my head. And I would come home from work and I would just crawl into bed because I was just overwhelmed. And the advice that I got was to learn how to compartmentalize my daytime work from my family and from the rest of me, and to somehow or other be all in when I'm doing clinical work, but learn how to close the box and not be all in for the rest of the day as well. I think my husband and I planned it out pretty well in that we made sure that we were established in our professions and married for almost 10 years before we started having babies. So I did not do what some of the people that are training with us now do, which is to have a baby and grad school and work all at the same time. I have no idea how they do it, frankly. I didn't do it. I waited until I started out young, but I waited until I was quite established so that I could take some time off and have babies. And then I took 3 months with my first baby and 3 months with my second two babies. And then came back to work only part-time when I had 3 kids for at least a couple of years. And I think that, I honestly have no idea how people do it, the people that I'm training now, how they do it. So I have no advice on that. I would say that the biggest paradigm shift and change in my professional life was reading Claire Weeks. That was a complete aha moment when I realized she was onto something that nobody else seemed to know and seemed absolutely right. And it turned my head around. And once I made that paradigm shift, it turned me in the direction that the rest of my career went. So I would say that she probably would top the list. I actually helped Judith Hoare, advised her as she was writing Claire Weeks's biography called The Woman Who Cracked the Anxiety Code, which is a biography. It is a fascinating woman who in her day actually was not taken seriously as a woman, even though she was a physician. But I would put her first on the list as an influence on me. And beyond that, I would say it was more personal influences, people whose names wouldn't mean anything. Well, I'm going to go all the way back to its precursor, PSA, because the Phobia Society was one of the very first consumer-driven advocacy organizations in the mental health field. It was absolutely the first. And by bringing together researchers, clinicians, and sufferers, the field went forward. Before that, I think everybody was in their own silos and doing their own work. But there wasn't anything that was coming out of that work that was directly practical, changing people's lives. And by having the hybrid organization, which was really Geraldine's idea, was to put all these people together in a room and make them interact and make them see each other's point of views and create a field. And that's what happened. So in the beginning, I think OCD and PTSD were included in the anxiety field. This is, again, we're going way back. And over time, I think OCD has got its own chapters in the DSM, and so does PTSD. But in the beginning, anything that seemed to have a lot of anxiety involved was part of the mission. And then gradually it got more differentiated over time. The OCF was started. ISTSS started, and there were other organizations for trauma and for OCD. But in the beginning, that was where the field was. And anyone who was involved in research, all the way from Don Klein or Jim Ballinger, people doing biological research, pharmacological research, all of those people, we got in the same room with the patients who were saying, well, that's all very fine and good, but what about menopause? Or, yeah, it works for a while, but it doesn't stick. Or people who were doing, epidemiological studies, or people who were doing the initial work, David Barlow's multi-center study. All of these people were informed by actual patients or people who were suffering and not getting help. So I think that's what formed the field. I would never have met all the people that I met. I mean, because it was a tiny group that then grew and grew and grew, and I had a role to play in that group, I met people that I would never have had the opportunity to know and to interact with and to learn from. So all my professional colleagues all over the United States and Canada, and bits and pieces of people from other countries, that's how I met them. And the annual conference was an extremely important part of my life, because that's where I got ideas, that's where I gave ideas, that's where ideas were developed, and also relationships with people. So we could refer to each other in other states, we could collaborate on thinking about things. That was my home, my home group was the ADAA.